Next, we will move on to dealing with nucleus drop during phacoemulsification. I would like to call upon Dr. Indu VP to deliver a talk. She is a senior vitreoretinal surgeon at Chaitanya Kottayam. Over to you, Indu.
Good evening, everyone. So you have seen a lot of complications that can happen during a phaco. So one complication that every cataract surgeon will experience at some point of the time, at some point of their life, is a nucleus drop. And every cataract surgeon should have a detailed plan to deal with this complication. So preoperatively, all cases should be assessed for eye-specific or patient-specific risk factors which make them prone for a nucleus drop. And the most important thing is to plan ahead. The record system must warn the operating surgeon of the condition, because in most of the places, the operating surgeon may not have seen the patient preoperatively. In high-risk situations, it is always best that a vitreoretinal surgeon also sees the patient preoperatively. And then you have to communicate properly with the surgical team that make a note of the high-risk case on the OT list and prepare for a VR backup. And communicating with the patient is also very, very important, and include this in the consent. If you anticipate that the nucleus might drop intraoperatively, you can take even a consent for a lensectomy and vitrectomy. Save unnecessary stress by posting such patients before just a public holiday or at times when a retina coverage is very limited. Always liaise with the retina service. That is, if you don't have an in-house retina surgeon, you can make friends with retina colleagues outside the hospital also, and establish a protocol for referring a patient with a drop nucleus. Intraoperatively, now you have made all the preparations, and mid-flight you find that the plane is going to crash. So now how are you going to land this crippled plane? So surgically, intraoperatively, once you find that the nucleus is dropping, the first rule is to accept it. There is very little that you can do to prevent its fall. So you remove all the instruments from the eye, maintain your composure, and plan what you're going to do next. Do not give in to the temptation to fish into the vitreous cavity with a phaco tip, because that can cause very disastrous complications like a giant retinal tear. Keep a cool head, avoid getting stressed. So most of these patients are under local anesthesia. So when the surgery is getting delayed, they will understand that something is not usual, and they get agitated. Reassure the patient that everything is under control. The OT staff must be made aware of the problem, and they should enact quietly and efficiently without creating a panic environment in the OT. So basically, as an anterior surgeon, what you have to do is to clear the anterior chamber. Clean the anterior vitreous from the pupil. You can use the triamcinolone also. Clean the cortical matter in the AC. Ensure that the corneal wound is very sealed, and you can put a surgical suture also, and make sure that the pupil is round. Now, the second question that you will have is to whether they implant the IOL or not. IOL can be placed if only very small amount of nucleus material, the cortical material has gone in, and if there is an adequate capsular support. But it is better left aphakic if large chunks of the nucleus has gone in, and if you're not sure of the capsular stability. So the problem here is sometimes during vitrectomy, we might have to remove the large chunks of nucleus material anteriorly. In such cases, you will have to remove the IOL. Secondly, sometimes during vitrectomy, if you find that there is a retinal problem, you will have to put tamponade. Tamponade is usually silicone oil in most of these cases. So if the IOL is unstable, silicone oil starts leaking anteriorly into AC. In such a situation, you will have to remove the IOL. And thirdly, sometimes if you're not very sure of the capsular stability, the IOL also sinks in. So in some cases, I have had to remove both the sunken nucleus and the sunken IOL. So if you're not sure of it, better leave it aphakic. And better to avoid complicated IOLs like AC IOL, SF IOL, iris claw IOLs in the same sitting, because they can compromise the corneal clarity, causes poor dilatation, makes the vitrectomy very, very difficult. So it's also difficult if you're planning a tamponade. So post-operatively, you're going to encounter glaucoma as well as inflammation. So start the patient on topical steroids, antibiotics, and topical IOP lowering medications. And once everything is over, sit with the patient, communicate what has happened properly. They will have a lot of questions which we will have to answer patiently. Be positive and clearly set out a plan for the patient. Arrange for a retina referral and communicate with the retina surgeon what has happened intraoperatively and what has happened postoperatively, and whether you have implanted the IOL. So when we get patients like this, there are two options for us. One, you can do the vitrectomy in the same sitting if an in-house VR surgeon is there, or you can postpone the surgery for 1 or 2 days. The advantages of the same sitting VR surgery is that it avoids two surgeries and it avoids undue anxiety for the patient. But it has got a few disadvantages also. One, you have to convert to LA. So you can give a subtenon block, that is not an issue. But because of a lot of manipulation by the anterior segment surgeon, you will encounter small pupil corneal edema, which will hinder your view. So vitrectomy becomes very, very difficult. Then most importantly, you have not taken a consent for vitrectomy or tamponade. So as I told, intraoperatively, sometimes we encounter retinal breaks, retinal detachment. So then you have to put oil. So these patients will have a poor post-operative visual acuity. They will have oil-related issues, and they will have to remove. We'll have to remove the oil after a few months. So all this, explaining all this to the patient post-operatively is very, very difficult. They are less accepting, and patient may already be agitated, and they become less cooperative for when you extend the surgery for 1 more hour. So all this turns into advantages when you postpone the surgery for 1 or 2 days. Even you can do the surgery as a second sitting on the same day itself after explaining everything to the patient. But the disadvantage here is that too much delay can cause an uncontrolled glaucoma or inflammation. So surgically, we always do a 3-port vitrectomy, and 1 port is converted to 20 gauge for a fragmentome. And the nucleus is removed using a cutter or a fragmentome. So this is a short video on what we do. So here we are making a 3-port vitrectomy. 1 port is converted to 20 gauge for a fragmentome. So here 1 port is removed. It is enlarged for a fragmentome. And then using a fragmentome, the nucleus is pulverized and it is removed. So you can see this is a high myope. You can see a lot of myopic macular degeneration. So this patient was taken up as a second procedure after taking a proper consent for vitrectomy and tamponade, because intraoperatively there is a very high chance for breaks and retinal detachment. So fortunately, the patient did not have a retinal detachment or a break, and I could leave the patient without any tamponade. Okay, so the take-home message that I would like to give you is maintain your composure when you deal with a problem. Communicate properly with the patient to avoid any future issues. And a timely referral is absolutely important, because there have been patients coming to me 1 month after the procedure. Thank you.